time. And with that, I'd like to introduce Phyllis Foxworth. She's the Vice President of Advocacy for DBSA National, and she's going to share with us some information about resources that DBSA National makes available to grassroots advocates. So thank you, Phyllis.
Great. Thank you, Andrew. It's so nice to be here to share this with you. Welcome back, those of you. I hope you had a nice break, and thanks for coming back. Because as Andrew said, I'm Phyllis Foxworth. I serve as the Advocacy Vice President for DBSA, and it's been my honor to serve as that Advocacy Vice President for the past 7 years. And we got to meet many of the people that I've worked with over the past 7 years this morning. So, and welcome back to all of you advocates as well. Over the next 30 minutes, I'll share with you advocacy highlights from the past 7 years and provide an overview of DBSA advocacy priorities and let you know how you can get involved. All right. So a core value, one of the core values of DBSA advocacy is to amplify the peer voice. So this timeline demonstrates just a very small snapshot of all the work the national organization has done to make sure the peer voice is heard and is front and center around legislative and policy decisions that affect us. So it's not everything, it's not meant to be comprehensive, but very quickly, let's just review some of the highlights. In 2013, DBSA partnered with the National Council for Behavioral Health on Hill Day. At that first meeting, we had 25 DBSA attendees. This year, over 1,700 attended the virtual program, and 42 of those shared that they were affiliated with DBSA. And over 2,700 people on that day of action took action. In 2014, the peer voice was represented when DBSA appeared on the national stage for the first time at a Hill Day plenary session. And we were there with NAMI and Mental Health America, where we had the opportunity to discuss each organization's legislative priorities. So there we got to represent the peer voice around legislative priorities. 2015 saw the inaugural issue of the DBSA advocacy newsletter, Making Mental Health Matter, as well as an action alert platform that enabled us to reach out to you, the advocate, asking you to take action on important legislation. After meeting with US senators who sit on the Veterans Subcommittee in 2016, DBSA was asked to help write legislation that opens the door for peer specialists and the services they provide to be available to veterans at the primary care facilities. So this action supported the peer specialists that are already serving at all 500 of the behavioral health facilities. That action was enacted through an executive order several years earlier. 2017 saw the list of DBSA advocates grow to over 8,000 subscribers. I think Andrew touched on that this morning. And they receive DBSA action alerts from DBSA as well as our advocacy newsletter. After much effort on your part, you the advocates, the PEER Act was signed into law in 2018, and now 30 new pilot sites have access to peer support at VA primary care facilities. And there is a special emphasis on ensuring that there are female peer support specialists with this act. 2019 saw the relaunch of the Making Mental Health Matter newsletters with more focus and emphasis on DBSA legislative priorities. 2020 has been an extremely busy year. When we'll get into that later, everything that we've been doing in 2020. But just 2 weeks ago, legislation we've been working on to have peer support services recognized within Medicare was introduced. This legislation was supported by leadership from DBSA chapter advocates and through a coalition that we work with. And I think it's important to point out that we reached out to chapter advocates in Nebraska who had a meeting with the co-sponsor of the legislation before he had made the decision to be a co-sponsor. So going back to Kimberly's point this afternoon, this earlier today, we called on those people and they showed up. And it was because of that we found a Republican sponsor for the legislation, and it was introduced just a few weeks ago. So now let's take a look. So I just want to say, all of you advocates out there, take a bow, because all of this has been accomplished because of you. This was not DBSA National doing this. We just were the orchestra leader. It's all the work that you've done. So like I said, this is just a snapshot of what we've done, but just some major highlights. And it's because of you, the advocates, that we've been able to accomplish this together. So unfortunately, there we go. I'd say no, the little advanced slide is hidden by the logo at the bottom. So effective advocacy requires focus. And I'd like to use the examples of environmental advocacy to illustrate that point. If one tried to take care of all the issues around the environment, one would be split in so many different directions that nothing would ever get accomplished. So an organization that is focused on clean air focuses on clean air and makes that their priority. They leave protecting endangered species to another organization that focuses on that. So it's no different within mental health space. So, I want to share with you what our priorities are. Our first priority is ensuring broader adoption of peer support services. We are, after all, an organization that was founded on the idea of peer support. As I discussed earlier, much of our focus has been on ensuring that there's peer support access to our country's veterans. But we are just as concerned about the general population, don't get me wrong. Our strategy is to grow and develop the peer specialist workforce, creating broader access to peer support services for everyone. So key to that strategy is ensuring that federal and local governments are supporting best-in-class peer specialist training, and that we have funding for peer support groups. And I want to bring up what Kimberly talked about this morning about getting peer support services paid through Medicaid in Texas. That is a great example of this. All right. Equally important is ensuring that peers have access to quality mental health services. Our efforts here are focused on implementation of the mental health parity law. This 10-year-old law stipulates that insurance plans must provide mental health care benefits at the same level that that they cover their physical health care benefits. Andrew talked about this morning. We are particularly concerned that insurance networks have an adequate number of clinicians to ensure that peers have timely and quality access to care. And this comes up over and over again, that we hear from our community that, parity, it's all fine and well, but if I can't find a clinician in the first place, parity, doesn't matter. All right. We also advocate that peers have access to medical products. We believe that decisions around therapeutic interventions are discussions between the peer and their clinicians. Our current healthcare delivery system can put up barriers and interfere with that peer-clinician relationship by putting the shared decision-making in the hands of third-party payers rather than the patient and their clinician. We believe that shared decision-making should rest entirely with the peer and their clinician. And so we'll get into some examples of all of these in just a moment. So first, let's take a deeper look at these advocacy's priorities. As a peer organization, our number one advocacy priority is making sure you, your family member, and friends have access to peer support. So what do we mean by peer support? There are certainly many ways peers provide support for each other. For the purposes of legislative advocacy, we are focused on these two. The first centers around peer support groups. These mutual aid groups do not provide treatment, but they provide social, emotional, and informational support focused on taking responsibility for one's own sustained health wellness, and recovery. Keeps getting in the way here. So I want to share with you that we did a recent survey with Pepperdine University, and they what we learned from that survey around the value of online peer support groups. 29% reported increased optimism and control over their future after attending a support group meeting. 19% reported improved acceptance of their mental health condition. And 18% were more confident about their treatment. And 10% reported enhanced self-esteem. So this ties in directly to what Douglas was talking about this morning on our panel, the need for there to be data. So this really helps us when we go to speak with legislators and regulatory agencies that there is around the evidence of those peer support group meetings. The other area of peer support services are those that are provided by certified peer support specialists. So this below here is SAMHSA's definition of the role of a peer support specialist. By sharing their own lived experience and practical guidance, peer support workers help the peers they work with to develop their own goals, create strategies for self-empowerment, and take concrete steps towards building fulfilling, self-determined lives for themselves. DBSA deploys a wide variety of advocacy strategies to increase access to these services. One significant way is to make sure that the federal government is funding SAMHSA in the first place. And even more important, specifically providing direction to SAMHSA to use some of those funds for peer support services. Now, it's important for you to understand that 80% of SAMHSA fundings are state block grants. The individual states then allocate that funding. So you as an advocate, you can make sure the funding is used properly to deliver peer support services in your communities. So there's, again, a local role that you should and can play. We also ask our congressional leaders to direct government agencies such as SAMHSA to direct some of that funding directly towards providing peer support specialist training. And as we talked earlier, as I shared earlier, ensuring peer support services for our nation's veterans is a major advocacy priority at DBSA. I spoke about the PEER Act earlier. DBSA was key to bringing awareness to congressional leaders for the need to have veteran peer support specialists employed at the VA physical health care facilities. Already, as I alluded earlier, because of an executive order about 8 years ago, there is a requirement that there be a veteran peer support specialist at every VA behavioral health facility. So DBSA supported this executive order by working with the VA to create the curriculum to train these veterans. Last year, we worked with the VA to enhance the 40-hour training to a 5-week veteran peer specialist course. So DBSA provides this course to VA employees through a contract with the VA, but we also provide this course to non-VA employees who want to pursue being a peer support specialist as a profession. And so what we did there was we applied for and ensured that we received Chapter 31 benefits. And this is a benefit that the VA offers to veterans to have those who are in rehabilitation training, that they can take courses in education and the VA pays for that. So with these Chapter 31 benefits, all veterans can have access to the DBSA's peer specialist training. So this year we're working with the VA. In fact, with congressional leaders. I have a meeting next week with the 2 sponsors of the PEER Act, but to expand the PEER Act, it was a 2-year demonstration project. And we are going to be working with those congressional leaders who sponsored the original PEER Act, asking them to make it a mandate now instead of a 2-year demonstration project, because the VA is proving that it's working. But we're also then going to be asking them to work with appropriations to allocate funding to pay for the peer support specialist, and funding to train those peer support specialists. We heard from the VA when they were choosing the 30 sites that it was the economics was the only factor that was a barrier to their decision, that they didn't know how they were going to pay for this at their individual facility. So that will be part of the conversation we have with the next week with those congressional leaders in how we can make the PEER Act permanent and how we can get funding for it. So now let's take a deeper look at our priority around access to quality mental health care. As mentioned earlier, especially Andrew was alluding to this in the panel this morning, Mental Health Parity celebrated its 10-year anniversary this year. This federal legislation applies to all insurance plans that provide mental health. So if your healthcare plan does not offer mental health coverage, mental health parity doesn't apply. The major components of the law state that a health insurance plan that offers the same level of benefits for mental health as the plan does for its physical health. The loophole is if they offer mental health services. So remember I said if your plan offers mental health services, but that loophole got closed with the passage of the Affordable Care Act in 2014. So the ACA, also known as Obamacare, identified essential health benefits that all health plans, not just the ACA health plans, but that all health plans must include. Among those benefits are prescriptions and mental health care. So now, because of the ACA, all plans must offer mental health care. And since all these plans offer mental health care, most of them then now, the mental health parity laws now become applicable. So repeal of the ACA would roll back these protections to the day before the health plans were not required to offer mental health coverage. Um, 2016 saw another milestone when the Center for Medicare and Medicaid Services issued rules that mental health parity mandates also apply to Medicaid managed care plans. So, and Kimberly talked about Medicaid being reimbursing peer support services in Texas, while the federal government had also made the ruling that the mental health parity laws refer to all of those Medicaid plans being offered in the states. And here's something very important that you all need to know, that most mental health parity enforcement takes place at the state level. That's why your state level advocacy is so important. Andrew talked about a little bit about this on the panel this morning. So why is that? Because other than the large self-funded employer plans, most health insurance plans are governed by the state. So while it's true that the mental health parity law is 10 years old, implementation has been very slow. And I think, Kimberly alluded to that about the need for that ombudsman in Texas. Advocates at the state level have taken up a charge, like Kimberly, and they work to pass laws that provide proper implementation at the state level. Andrew talked about some of the wins. Well, he talked about court wins, but Andrew can share with you that later about some of the federal, the state wins. DBSA belongs to a coalition that's focused on state level implementation with the Kennedy Forum. And we keep advocates apprised of what's going on at the state level, including wins in your state. So if you've been reading Making Mental Health Matters, Andrew's been informing you about those wins. So that's kind of what he alluded to this morning on the panel about the need around making mental health matters, that education. So here are some examples of mental health parity in a practical application. The first example demonstrates what it means to provide the same level of benefits for mental health as the plan does for physical health. And this example is applying to the number of visits. So if your mental health plan states that you're able to see your cardiologist 12 times a year, then as a specialist, you should also be able to see your psychiatrist 12 times a year. In other words, the plan can't be more restrictive on how often you're going to see a mental health specialist as it does a physical health specialist. This next example, illustrates parity with regards to out-of-pocket expenses. There must be equity or parity between what you pay for mental health care as you do for your physical health care. So, for example, if your out-of-pocket expense for an office visit is $50 to see that cardiologist that I just used in that previous example, then the cost of the office visit for the psychiatrist also has to be $50. It can't be more. There needs to be equity. They need to be the same. And so this final example applies to your annual deductible. A deductible is the amount you must pay out of your own pocket before the insurance plan starts covering the cost of your care. In the past, it was not uncommon for health insurance plans to have two separate deductibles, one for physical health and one for mental health. And often the deductible for the mental health was much higher than the deductible was for physical health. But today, because of mental health parity laws, it doesn't matter. There can only be one deductible. And it doesn't matter whether your physical health insurance, your physical health care coverage applied towards that deductible, or your mental health coverage applied towards that deductible. There's only one deductible today. Just as important is access to mental health services is access to medical products, specifically medications and devices. There are many ways both commercial and government insurance plans might present barriers to the peer and clinicians' shared decision-making around your preferred treatment options and outcomes. The first barrier is to not provide reimbursement for medical devices and lab work, or by not including a medication on a plan's formulary. So what is a formulary? A formulary is the plan's list of all the medications that they will include for reimbursement. Within that formulary, plans have tiers, and the reimbursement to you is different based on that tier. For example, a genetic medication is typically in a lower tier. And then as you get, as you move up the tiers with more and newer medications, the cost to you, the co-payment for that medication rises. So our advocacy is both centered around making sure that the insurance plans include all of the medications on their formulary, that they're not excluding some of the medications, and also that they have a reasonable out-of-pocket expense. An organization I know that Andrew's been involved with in Illinois, for example, is called Cap the Copay. And this is a good example of where your advocacy doesn't necessarily have to just be with other mental health organizations. Cap the Copay is an organization of physical and mental health groups that see a large cost for their medications. And so we partner with them and with other organizations such as leukemia and other patient advocacy organizations where they have high out-of-pocket medical costs for medications. Insurance plans have other policies that restrict your access to medical devices and medications. Prior authorization, for example, means that if you want to be reimbursed for the device or medication, you need to get prior approval from the insurance plan. If you don't, you could end up eating that entire cost yourself. Non-medical switching is a very severe interference, as far as I'm concerned, in the peer clinician shared decision-making around what your own preferred treatment options and preferred treatment outcomes are. In this case, the plan will inform you that they've decided that you should be on a different medication. Step therapy can be particularly dangerous and problematic, especially if you change insurance plans. So this policy states that you must start on the insurance plan's preferred treatment and fail on that treatment before they will let you try a different medication. It doesn't matter if you've been using a particular medication for years with success. If the plan requirement has a step therapy policy, you might be required to follow a treatment plan that you know doesn't work for you. And you'd be required to fail on that first before the insurance plan will authorize you and your clinician's preferred course of treatment. And this happens when people change insurance plans. So at DBSA, we address these issues when we learn about them. And again, keeping in mind that insurance is regulated at the state level. These are state level issues. It's important, so therefore it's important that you advocates stay on top of these challenges when they arise. Many states have drug utilization boards that decide what devices and medications Medicaid plans will cover, for example. And with that, they'll put in those formularies. Remember, the formulary I said was something that, you know, is a list of all the medications and devices that the insurance plan is going to cover. And so these drug utilization boards do hold periodic meetings. And it's important as a state advocate that you know when those meetings are, because DBSA National, we can help prepare you to speak at those meetings. And again, I can tell you from experience that having a peer speak at a meeting, whether it's, you know, a regulatory meeting or a hearing of the representatives or the senators at your state level, that when they hear from the peer voice, it matters. So we can help prepare you for that. DBSA has written many letters to Medicaid directors when we hear about this, as well as insurance companies. Andrew just recently wrote letters to insurance companies about their refusal to include a medication in their formulary, for example. But it's important that you make us aware of these, because we can respond once we know about them. So, as you can see, central to our advocacy is education. By educating peers about our priorities, and just as important, how laws and health policy decisions will affect our access to peer support, quality mental health care, and medical products, we're better able to mobilize. So change is possible, but change is much more effective when there's a movement. And there are many reasons why it's challenging to motivate people. I don't know if you talk to Kimberly with her enthusiasm, I'm not sure that she would say there's any challenges to motivating people. But you know, stigma cannot be ignored. You know, that can be a challenge. That's one of the challenges we face in motivating people. And I would just say that advocacy does take courage. But we also believe that by educating our community and activating them to participate, that we definitely can affect change. So what do? We have multiple ways to learn about the issues that affect you. First and foremost, I encourage you to subscribe to Making Mental Health Matters. All of the priorities that I have shared with you today are addressed in this twice a month newsletter. Once you have read the newsletter, so again, what are the simple things that you can do? Once you've read the newsletter, send it to other peers and send it to your friends, send it to family members and colleagues. So you can educate. Remember, going back to what I said, education plus mobilization equals change. You can start with the education today just by forwarding the newsletter. Email the newsletter to your support group participants. Many of you have gone to virtual meetings and now have the email addresses of your support group participants. You know, education equals mobilization. So I'm just going to say, it's our responsibility as advocates, and Kimberly certainly had the passion to demonstrate that it's our responsibility to educate people and get them to bring these issues to their attention. We also have a short advocacy webinar that outlines our priorities and has suggestions on how you can get involved. So one of the things that you could do is seek out other chapter participants that are interested in advocacy. Watch it together. You know, you can both be watching it on Zoom at the same time. Just you can have a Zoom meeting and you can watch the webinar, and then you guys can talk about ways and which you can mobilize in your own community. So now that you know what DBSA advocacy priorities are, and you have a little bit better understanding of why these issues are so important, I hope that you're encouraged to take action. So DBSA provides a variety of ways that you can get involved. We train advocates to take part in legislative and regulatory meetings. At those meetings, you can visit with your elected officials and you can share why these policies issues are so important. Today, these meetings are taking place by phone or virtual platforms. So it's actually a lot easier. You don't have to, travel to, you don't even have to travel to if you want to talk about federal issues, you no longer have to travel to DC. You can schedule, just like our chapter leaders in Nebraska did. They didn't travel to DC to talk with the representative who sponsored the bill. They did it through a virtual or phone call. So, at these meetings, you can provide testimony to agencies, such as what we talked about with the drug utilization councils. We can provide small group trainings. If you and some of your chapter members want to take on advocacy, we're more than happy to provide those. As I said before, subscribe to our advocacy newsletter. This allows you to stay informed and receive action alerts from DBSA when it's appropriate. So one of the things that Andrew talked about this morning was educating people on the topic. So then when you get that action alert, he doesn't have to rely on that small email to educate you. You already know why it's important, and you've already informed your other peers, the chapter members, your family members, your colleagues, and you can send forward that action alert to them because they've been educated. As mentioned earlier, DBSA sends comments and support letters to elected officials and heads of state and federal agencies. These letters can be found on the DBSA website on a variety of topics. So you can go out there and use those as letters as a template to write your own letters. And I will just share that if we have any chapter leaders on the phone on the meeting here, that sending that letter out as a chapter leader gives you an additional weight. So as you look at the templates of the letters that we sent, you'll see where we always mention how many DBSA participants we represent. So DBSA has a wide variety of bills that we're following at the federal level. So I've been talking to you about the state and how you can get involved in your state level advocacy. So now I want to switch gears and talk a little bit about some of the federal bills that we have. Most of these have already been covered in Making Mental Health Matters. That's why it's so important that you subscribe and you read Making Mental Health Matters. And I will also say that if you are a subscriber of Making Mental Health Matters, you've received action alerts about these bills when it was appropriate. And I can tell you, we know how many people respond to our action alerts, so we have great opportunity to provide even more peer, more opportunity to amplify that peer voice. I've already talked about our priority to work with congressional leaders to make the PEER Act permanent. I have that call with them next week. The next two, however, I want to talk to you about are the Virtual Peer Support Act and the Virtual Community Support Act of 2020. Last March, DBSA reached out to all members. We sent a letter to all members of the US Senate and House, specifically asking them to draft legislation that would enable our chapters to move to from in-person to virtual online support group meetings, as well as provide funding for peer support specialists that were going to be needed out in those communities. We did have two members of Congress, one in the Senate and one in the House, who were very interested in working with us on that. The Senate Bill 4416 is the Virtual Peer Support Act. That specifically gives requests funding through SAMHSA for community organizations such as DBSA, to have funding for them to transition to virtual peer support group meetings. So this would be funding that we could go out and help our chapters as well as provide training for peer support specialists, as well as to provide one-on-one peer support services. The House bill, it's not a companion bill, but Representative Kennedy worked on that bill, and it's a much broader bill, but they did include language in there that would give funding directly to those community-based organizations. I want to share that we had a chapter leader in Nevada that Andrew reached out to when we were working with Senator Cortez Masto on this bill, and she personally wrote a letter explaining her reasons why she felt this legislation was so important. Trust me, that one letter from that chapter leader telling her personal story as to why it was so important was instrumental in helping the senator move forward with that legislation. I also, just to Kimberly's point this morning, want to share that that individual later on in the year, so that bill was introduced in July, in September, late August, September, the senator's office reached out and said that they were going to be doing a town hall back in Nevada on mental health. And so we were able to put her into, we were able to give her the connections with that chapter leader who provided that personal letter to serve on this mental health roundtable. So imagine in just a short time, like Kimberly has said, all it took was someone willing to do the first step. And now that individual is becoming a mental health advocate in the state of Nevada. There are some other bills that we are following. There is a Partners Act. That is the bill legislation that provides funding for peer support specialists to be staffing warm lines. And so what better person to be on a warm line than a peer support specialist? And then we also have bills that we are sponsoring that would strengthen the behavioral health parity bill. And again, as we shared with you, it's a 10-year-old bill, but implementation is slow. And I think that Andrew kind of shared with you this morning as to some of the reasons behind that. So this is not changing the bill, the original parity bill, but adding some teeth around implementing that bill. All right. So as you can see, advocates are key to our success here. We cannot do it without you, the advocates. So to support you, the national organization has a variety of tools to provide you with both education about the issues as well as training to be an effective advocate. Some may be most comfortable contacting your elected officials. Others aren't ready to take a more active role. A good place to start is serving on a DBSA peer council or participating in a DBSA focus group. We convene these councils from time to time to learn directly from peers on a wide variety of topics. So then after you've dipped your toe into advocacy, you might be ready to be more public. Our ambassador program trains those who are willing to share their experiences with legislative committees and the media. We offer training on DBSA values, use of compassionate language, and Kimberly alluded to that this morning with the training that she had received from DBSA. It's up to you, really. At the end of the day, it's up to you to choose what area you are most comfortable in getting engaged and involved. But just know that we are here to support you. We have these tools in place wherever you feel that you're most comfortable engaging. We've had many success stories, including how to mobilize. Kimberly certainly shared about that. And all I will end with that, say that it takes the first step. And I invite you to get involved today by joining us at www.dbsaalliance.org. Take action. So take that first step. As Kimberly said, there's a reason why you are attending today's session. It's something that's of interest to you. So you already took that first step. I'm now going to turn it over to Paul Simmons. He is another great case story of advocacy at the state level. He's been doing wonderful work with the California State Organization to get them mobilized around the issues that are important in California. So I'm going to stop my share screen and let you take over, Paul. And as you have questions, please submit them in the chat box, and Paul and I will be happy to answer your questions at the end.
thank Phyllis and Andrew and Eric and all the DBSA team for putting this together. Am I still muted?
No, you're good.
Oh, good. Yes, certainly, for putting this all together. I know that there's some information about me in the initial website there, but just wanted to mention that I'm both an individual with direct lived experience and the father of a young woman who grew up with bipolar diagnosis. So as Joni Mitchell would say, I've looked at life from both sides now. So in any case, I try to get my presentation up on screen. We'll definitely try. Sorry for the delay there. Let's see. Sorry. Okay, here we go. Huh. A second. Sorry. There I am. Sorry, it was off my screen. There we go. All righty. So, yeah, I'm Paul Simmons. My email's there. It'll be at the end of the presentation as well, so you can reach out to me at a later date. First, I'd like to talk just a little bit about the state organization. Back around 2015-16, Rusty Seelix, who was my old employer and author of one of the top statewide mental health initiatives ever, worked with Phyllis and some of the folks at DBSA and the National Council to create the peer-led California grassroots organization for a couple of years. And around 2017, we began advocating as part of the GO team, the grassroots organization. And with Rusty's retirement, I took the reins as community engagement specialist and continued on with the statewide organization. One of the key things we wanted to do with the core team is to make sure that it was geographically represented, people from chapters and support groups all around the state. And our original core team included representation from all these different regions: Sacramento, San Francisco, LA, etc. There was a state organization quite some time ago that really wasn't focused in advocacy. That sort of went fallow after a while, and we recreated the state organization in order to really continue the advocacy efforts we had done in the past. So in terms of advocacy efforts, there are a lot of levels of advocacy, as I think some of the other folks have mentioned. There's legislative, which of course, Phyllis talked about some of the initiatives that have been taken on a national level. But in collaboration with the National Advocacy Platform and listserv, we've weighed in on key legislation which aligned with our values and our legislative priorities, as well as a few other bills that we have taken up and followed and promoted, not heavily, but our main focus has been on the national priorities, but we've had other things that are a little bit under the radar for national being on a statewide level. The good news is that just in the last week, the governor has signed our two key bills. One was a peer support certification bill, which we did not have in California. We did not have state recognized peer support certification, as have been in 47, 48 other states. It's now state recognized. It was slightly watered down so that it's not being implemented at the state level. It's being implemented at the county level, but it's a huge step in the right direction. And secondly, a bill that was put together on mental health parity, which of course we have the federal law already, but the state really wanted to undergird that effort. I think the primary function of that bill was supposed to be to ensure that if some of these gains were reversed or watered down by the current administration in Washington, D.C., that California would continue. I think the other key there is the fact that that mental health parity, as Phyllis mentioned, is in fact enforced at the state level. So to have it in code in the state became very important to us, and we managed to get that through as well. So it's been really great. Regulatory, the Department of Insurance, Department of Healthcare Services, as mentioned before, a lot of the parity and other issues that we have of concern are done at the state level with the different agencies. We have a state insurance commissioner and a Department of Insurance. Department of Healthcare Services, the primary manager of Medicare in the state. So we also are connected with them. And we also have been working with the Mental Health Services Oversight and Accountability Commission, which is basically the organization that manages a lot of the funding that we gained through the Mental Health Services Act that I mentioned before. And of course, personal advocacy is key. While the state does, in fact, enforce parity laws and other such things, they don't keep track of them. And so it's important that we at a personal level do advocate with our doctors, with our carriers, and certainly our organizations, whether it be the national organization, the statewide organization, or just your local support group or your local chapter. We can help people to advocate due to our knowledge. We've done a number of parity presentations around the state, and I think that has really helped in terms of that. And then the mental health community, we have policy partners, primarily insurance companies, have worked very well and very closely here with a coalition that's been around for about 25 years. So they are on board with our parity issues and a lot of our other things. But then other organizations like NAMI, as referenced before, REMCO is concerned with disparities in mental health provision, primarily racial and ethnic disparities. But there are a lot of organizations here in California that do that sort of thing. So when we put together the state organization, I should say again, we had the core team, which became our executive committee and then a board, and we established a new 501c3, a new nonprofit agency. We, at least in theory, put together regional councils. California is a big state, and it really helps to have a little bit more regional organization and communications, just because there are so many chapters and so much happening in the state. And support groups, of course, the chapters and the support groups are always at the ground level. That's where the rubber meets the road, and that's where the information that we get really brings things together. Some of the challenges we've had, continuity in terms of putting together the organization. When you're dealing with mental health and mood disorder peers, people often need to take time off to handle their personal mental health and their personal lives. And of course, with any organization that's volunteers, which is pretty much everybody in terms of boards, that's a factor. But particularly with our community, that's been a challenge for us. But I think it's been, with our core team, we've been able to keep a big presence there. And with funding, we are swimming with the sharks. But in terms of funding, there are a lot of people going after what's a fairly large pie in California, particularly. But keeping the organization funded so that we can do some of the things we really want to do is always a challenge. And that's the case with any organization, whether it be national, local, or statewide. So that's the organization as we put it together. Now, what we've actually accomplished has been really pretty amazing in just a couple of years. Actually, we became a 501c3 here only about a year ago. We've been working on it for 2 years, but we actually got our nonprofit status a year ago. And I mentioned my previous boss, Rusty Seelix. We actually dedicated to him. He's since passed. And so we put together our soft skills suite, which is basically a continuation of some of the health fairs that we put together kind of under the wing of National, and then individual workshops on various issues that we've reached out to our chapters and said, hey, what do you need from us? How can we help you And some of the issues are just, hey, go to national, go to the website, which is an amazing website. If you don't go there often, go there often. It's there's just a tremendous amount of information there, a lot of resources. But then we've actually developed different little workshops that we can put together just for the chapters, but pooling our expertise from around the state in order to give support to them. So that's been great. We actually got some funding from Cal Mesa, which is, I mentioned the Prop 63, the Mental Health Services Act. That's where a lot of the money comes from innovation in the state. And we did get a pretty good grant for that for a workshop series. Our legislative advocacy, again started by the grassroots organization program with the national organization and Phyllis and Andrew. That really has blossomed even since then. We've continued the march, and again, we've utilized the resources at National to help us kind of put together some of our strategies for our legislative advocacy and some of the things we can do. Also, we've been using the listserv. Andrew sent out several alerts for us in terms of putting those calls to action together and to getting them out to everyone here in California. So that's been really great. And we've had many support and opposition letters, not just from the statewide organization, but from individuals, partially through that advocacy platform with the listserv. And finally, chapter support and collaboration. We now have what we're working on now. It's a new project, is a new chapter incubator. And that kind of ties in with our response to COVID and the need for social distancing. Virtually, no pun intended, virtually every support group now is working on Zoom or some other meeting program, some other virtual platform. And what we discovered when we went there was that we had a lot of people come back to our support groups who had kind of floated away from our support groups because of convenience, a lack of convenience. It takes an hour in LA to get 10 blocks. So it's really been interesting that we've gotten a lot of people back. So we're starting to actually begin new support groups or solicit people to come to new support groups on a virtual level because it's a lot easier now. And as COVID relaxes, we'll begin to go back to our local support groups. And but we'll probably keep the virtual ones because some people will, they're not gonna drive half an hour to get dressed, put your makeup on, whatever you have to do, and then get to your workshops or to your support groups and then go back. It's a lot easier to do it virtually. And so that's mostly sort of the gist of what we've done with our state organization. It is a young organization. We feel like we've done an amazing amount of work, both with national support and national's direction, and since we've had our own 501c3 continuing in partnership. Please feel free to ask any questions, of course. We'll get to that. I'm sure you've been sending a couple for both of our presentations, but you can reach out to us at our local our website, which honestly, we're not using a lot. We're using social media so much now that our website's almost an adjunct to that. But it's really kind of a new website. It doesn't have a lot yet. On social media, we're at DBSA Cali. And then that's my email address below that. And then John Vanover, who's our legislative chair, who's really been our key person here in California, along with myself on legislative and other advocacy issues. That's his email address. And of course, I'd be happy to share that with you and do what you like with it. So thank you very much. I hope I didn't speak too fast. I didn't want to run over time. So here we are. Thanks a lot. I'll send it back to Phyllis.
Nope, that's me. And thank you both for giving us so much information. I put the www.dsanational.org DBSAcalifornia.org into the chat because you can't copy and paste that from Paul's shared screen. But if you'd like to go there and check out their website and see what they're doing as a state organization, I think that provides an excellent model for what grassroots advocates can do. I also put into the chat during the course of the conversation the dbsalliance.org/take-action, where you can sign up for our communications. I believe many people are already signed up for those communications. And then I also put in the link to the webinar that Phyllis had on her presentation as well. And that is an example of a place to get started where you can watch that webinar and then contact us and say, hey, I watched your webinar, what next? And we can pick up the ball from there and help you with your process and getting more engaged and more involved with advocacy. Eric, have there been any questions added to the chat?
We have not had any questions. Does anyone have a question they want to ask?
Okay, we'll give that a second and see if anyone puts any questions in the chat. In the meantime, I will explain what we're going to do next. So we're going to go into discussion groups. Eric, as our Zoom jockey, is setting those up. And when you get there, your microphone will be unmuted. You'll be in another room in this same Zoom call, but it will look like a Zoom call that you've joined for other meetings. There will only be 6 or 7 people in there. I'll be in one of them, and a facilitator is going to introduce themselves and ask you to introduce yourself. Your microphone will be unmuted. We will have discussion questions that are going to appear in the chat, and we're also going to, thank you, Eric, for dropping those in the chat. And we will also be, if you're a facilitator, go ahead and copy that right now, because you may need to paste that in the chat
They should continue over
when you get there, just to be on the safe side. We're also going to select a reporter to report back. So that will not be your discussion group facilitator. We're going to ask one of you to take notes and be prepared to talk to the large group and tell us what your small group discussion has come to as far as next steps and practical applications. So we'll be in those discussion groups for about 20 minutes. Then we're going to come back, and that'll take about 20 minutes for us to report out from those 3 groups. And I am going to ask both Phyllis and Paul not to join discussion group. Everyone else, you're going to get a magic little box that's going to pop up on your screen and say, would you like to go to a Zoom room? And there's an accept and a decline, or it might say yes or no, or it might say something to that effect, the affirmative and the negative. And say yes, and then you'll be whisked away to another call. And then after we have our discussion there, then we will all be called back into this large room. So
my understanding, that's going to be about a 20-minute discussion group.
yes.
Yeah, so figure about 20 minutes. Yeah.
Yep.
Okay, ready to go?
I'm all set. I believe we are all set.